I would like to invite Alan Manning to join us. And I was beginning, as I was reading Alan's bio, to wonder if Bill also had a partnership with Aer Lingus in terms of bringing expats back to Ireland, because Alan is another expat and very proud sort of Cork man, and we are very pleased that he has come to join us today. Alan is the Chief Operating Officer of Planetree in Connecticut. And Planetree is a non-profit organisation dedicated to enhancing patient-centred care around the world. Now, I think we'll have seen from sort of Harry's presentation and some of his analogies that the delivery of care has changed so dramatically over the last relatively short period of time, and definitely if you go back 100 years, it's changed totally dramatically. And when we think about the level of sort of specialisation in both technology and with clinicians, the real challenge then is how do you keep the patient at the centre of that care? And the more and more specialised the care becomes, I think the more challenging it becomes to keep the patient at the centre of it. So I'd very much like Alan to join us, and I'm sure he would be able to give us some great insights into how you keep the patient at the centre of healthcare.
Thank you all very much. Thanks for having me today, and thanks for having me home. I actually came on Delta, not Aer Lingus, which is a bit of a problem, and I'm not sort of a Cork man, I'm fully a Cork man. So yeah, the afternoon session seems to be taken over by the Rebel County, because I know Tony, after me coming up, we actually went to the same secondary school, so we're really keeping it close to home for the afternoon. In the honor of what Bill said earlier about alliteration and P's, I'm staying away from the podium for a very pronounced reason, and that's because when I was young, my mom wanted me to be a priest, and so all those P's scare me, so if you don't mind, I'm going to stay away from the podium as I start this. And the other P I want to talk about is if we want to really talk about engaging patients and changing the way we consider patient activation and patient inclusion, the best way to do it is to plagiarize. What I mean by that is there's many other countries around the world, there's many other hospital systems around the world who've done incredible things to engage patients. So I think it serves us best to use one of the quotes again, I'm just taking all of Bill's lines, is to stand on the shoulders of giants and figure out what other people have done and learn from what they do. So I'm here today to talk about how we can put patients first in a meaningful way. The organization I work with currently works with 700 healthcare organizations in 20 countries around the world. But before I jump into the details of what we do, I want to make sure everybody's awake in the room. And I have a quick quiz question for everybody, just by a show of hands. How many of you in the room got involved in healthcare to make a positive difference and to help people? Just so you know, it's really bad not to raise your hand right now. All right? Excellent. So I ask that question at most every talk that I do, and without fail, almost every time, almost all the people raise their hands. And if you didn't, it would really ruin the next couple of minutes of my talk, because it was the very first point that I put up there, which is that you're all individually patient-centered. I don't know anybody in all my travels who's gotten involved in healthcare for any other reason, or any other reason being the primary reason at least, than to help people. We want to help make a difference. Now, the challenge is, while we all got involved individually, I think we could also raise our hands and say we have a little bit of a ways to go to make it better systematically. How can we make sure we do it for every patient, every time? And that's what I'm here to talk to you about. But the key to understand first is that there's a lot of really good people in all of our hospitals doing good work. The second belief that we have is these principles hold true across the continuum. Somebody brought up in the morning session, I think it's very important, we can't think about this as a hospital setting anymore. This is about continuum of care. And even beyond the continuum of going from outpatient to hospice care and everything in between, we have to consider this as part of people's lives. Person-first language, not using people's diagnosis to describe them, but treating people in their lives. Because the reality is patients never want to be known as the diabetic or the person with the heart condition. They're a person with loved ones and with families. And the more we understand their life priorities, the better success we'll have with caring for them. And not only is that a moral imperative and a good thing to do, as I'll show you with some slides later, it's also a financially smart thing to do. Because the more success we have with our patients, the less likely they'll be to use invasive, high-cost procedures. And it's a very, very important thing to keep in mind. And the last thing is that these principles hold true around the world. Working in 20 countries around the world, I can tell you patients everywhere want the same things. They want personalized, humanized, and demystified care. It doesn't matter if we're working in Denmark or in Holland or in Qatar or in Brazil, people want the same things. One of the things that we've really started to realize is that there is that common realization from our members. And some of our members you'll see here from some of the sample countries, they all came to the same realization. We need to have better technology. I love that Formula One example that you showed earlier, because that's really what it is. We need to get faster, better, stronger. We need better technologies to take care of our increasing conditions and the challenges that we have with our patients. But all of these organizations also came to a realization that we can keep building more and more technologies, which we should do, but that alone is not enough. Because when I start asking these questions to people, and I start saying, are you as good at 3 o'clock in the morning as you are at 3 o'clock in the afternoon? Are you sure that your nurses and doctors on your night shift are as good as your doctors on a day shift? How do you ensure consistency across all of your staff, that people are delivering the care the way you want them to deliver it? And how do you maintain culture when things get really busy? Because the reality is, as much as patients need good quality care and need it on time, they also need you to look at them in the eye when you treat them. They also need to treat with respect and decorum when you come in front of them. So we hear so much all the time, and I just Googled some newspaper articles. Like our speaker this morning, I don't do the Irish Times, I do the Evening Echo to keep up with things, because there's better sports. And you'll see endless amounts of articles about what's happening in healthcare. And it can become very tiresome to constantly get criticized. And I'm here today to talk about more of a glass half full type of situation on this. But the only way that we can really address these issues is not by throwing just more technology and more high-end laser knives or linear accelerators, which are all key to what we do, but it's how we treat people when they come in. Because the special sauce to us solving this problem is engaged patients. How do we make sure that our patients take control over their care process? How do we make sure that they start taking ownership over their own health? That's the $64 million question of how do we make sure they don't go out and eat the wrong things, drink the wrong things, live the wrong way? Because that's what's driving up the cost. We can't just worry about how are we going to take care of this aging population when they come to us. We have to say, how are we going to take care of this aging population as they age where they are? But in order to be patient-centered, or in order to engage patients, the thing we have to realize is that we first need to engage staff. Because to be patient-centered, you first need to be staff-centered. What kind of cultures are we building in our organizations to support this movement? What kind of staff, how are we supporting our staff? How are we educating our staff? How are we making sure they understand all the practices? It's important to note here, when I talk about engaging staff, this is at a macro level. Systemically, how are we engaging staff? Because any problems that are happening in your organization are rarely a result of a bad actor or a bad staff member. I'm going to give you a story that I'm currently going through at the moment. I have an aunt in Cork who's quite sick. And a couple of months ago, I was talking to my mother on the phone, and I said, how's Joan doing? And she said, well, she's very frustrated. She's in the hospital, and she keeps pressing the call light, and nobody's coming. And I said, well, Mom, be very careful, because Joan is a stubborn Cork woman and a strong woman. And I said, if somebody doesn't answer our call light, she's going to get up and go to the bathroom by herself. The next night, literally the next night I'm on the phone with my mom, she's like, you won't believe what happened today. Joan got out of bed by herself, went into the bathroom, fell, smacked her head on the sink, and ended up falling between the sink and the toilet. She said, how did you know? I said, well, I've done this often enough to know if we don't answer people's calls, they'll help themselves. But the story gets worse. Not only did Joan self-ambulate, not only did she go into the bathroom and crack her head, she ended up soiling herself as a result. She was a fairly large lady, so now to help Joan out, they took her by her ankles and dragged her out of the bathroom. This is a private hospital in this country. I'm not saying it happens all the time, but I'm here today to express the realities of what happens on a patient basis. How would you feel if that was your mother or father, your brother or sister, your son or daughter? Joan's back in the hospital right now. And again, last night, my mom was like, we kept track. My mom was up there, and she thinks she's my intel to tell me stories. She's like, it was taking them an average of 7 minutes to respond to the call light. So she has a stopwatch out now, right? So now she's tracking it. She's your worst nightmare, literally. But 7 minutes. The next time you really need to use the bathroom, what I want you to do is sit back down and wait for 7 minutes and see how long it feels. See what that does to your experience. And then we found out last night the reason Joan went back to the hospital is because her diabetes is out of whack. And she was talking to the doctor, and she was showing her the pills. And when she left the hospital last time, they never prescribed her diabetes medication. So she's been off it for 6 weeks. And that's why she's back to where she is. So there's a hospital stay happening, a bed being filled today because we didn't fulfill the prescription right 6 weeks ago. It's not going to be fixed with technology alone. That was a process issue. So the key is, how do we start adjusting our processes to address this type of work? And the way we do it is by becoming systematically personalized. We can't implore people to be more caring, be more empathetic, be more compassionate. That's definitely the manifestation. That's definitely the outcome. But the key is, how do we become systematically personalized? And I became aware of that last year when I was doing some work in Denmark, a group like this, and we were doing a workshop for about 4 hours. And when you do a lot of these talks, you can tell who likes you and who doesn't like you in an audience. Audiences always fall into 3 buckets. There's the bobbleheads. Those are people who nod along, and there's a couple of them in the audience, and I love you because you make me feel good about myself. Keep nodding along, and I feel better about what I'm saying. Most people are skeptics. There are people sitting there listening to what you're saying, going, okay, fair point, not fair point, kind of keeping a score tab, or saying, he said he's from Cork, but he sounds kind of Canadian, because I get that a lot at this point, half my life in Cork, half my life in America. And then there's always 1 or 2 who are kind of throwing you the stink eye all the time. There's always 1 or 2 people in the audience who don't like what you're saying. And this day in Denmark, it was one where Mary's sitting on the far left side from me, and she didn't blink for 4 hours as she stared intently at me as I was talking. And when she raised her hand at the end, she really kind of reinforced one of our beliefs at Planetree, which is it's not what you do, it's how you do it. It's not just that you do something, but how you actually go about it. So she didn't just raise her hand, kind of like, excuse me, sorry, I have a question. She was like, and at that point, I was like, tell my wife and kids I love them. And I said, oh, you have a question? You know, like that. And she said, I don't have a question. And the men in the room will really, really resonate with this. I don't have a question. I have a comment. And I was like, right. It's been nice knowing all of you. And she said, what you're asking me to do is to be systematically personalized. And she meant it as a gotcha. You know, that's ridiculous. And I went to react because I was expecting a fight. And I was like, no, but you're absolutely right. The goal of everything we're trying to do in healthcare is to be systematically personalized, to make sure our IT systems, our technologies, our staff are all in a position so that when you show up in front of that patient, you can give them the most personalized care they can deserve. Because not all of our patients are the same. Because the reality is we try and treat all of our patients the same, we'll have a one-size-fits-none scenario. I did an exercise last week. I was in Massachusetts with a brand new behavioral health hospital, and we did some training around cultural competency. So I said, can you name 3 things that you can visibly see or know about me? And I said, well, you're a man, you're white, and you're Irish. Nobody said I was handsome, which I was deeply disappointed with, but those are the 3 that they went with. And I said, okay, tell me what you know about whites, tell me what you know about men, and tell me what you know about Irish. The first thing is the stereotypes they have about Irish people are horrible, right? And so we went down the list, and they had 4 or 5 things in each bucket. 80% of them were wrong for me. So if they took the cues in front of them and said, we've got a white Irish man, here's what he'll be like, they would have been 80% wrong with their judgment of me. So it's really important that we get to know who we're taking care of as individuals, because we're not all created the same. We're all created differently. But how do you go about that? The first thing you have to do is make sure all your staff are reconnected to their purpose. Do they all understand the important thing that they're doing? Because as we're sitting here talking in this lovely hotel with this beautiful food, there's somebody pulling into your A&E right now at your hospital, petrified. Their life just came to a stop. They can't catch their breath. They don't know who's going to pick the kids up from school. And you're just going, yeah, it's just pneumonia. They'll be fine. They'll be out in 4 days. But for them, they're very, very scared. So how do we make sure all of our staff every day understands the importance of what they're doing, the magnitude of what they're doing for each patient? But as much as purpose is important, purpose doesn't last long. We've all read a book or watched a movie or heard a song and said, I'm going to be a better man. I want to be better as a result of this. And it lasts about a week, unless we have a process to support it. So what we do with organizations around the world is help them develop processes to support hearing the patient voice and engaging staff in a meaningful way. How do we flip it from just the strategy you're developing for 2020 and say, how are we going to engage the staff to create the change from the bottom up? Because as much as the strategy is set from the top, the implementation is set from the bottom. What is that nurse doing at 3 o'clock in the morning to represent your strategic plan? Those are the things we need to be trying to fix. That's the X we're trying to solve for. But the final way you do that is by increasing and improving the practices of our staff. Do we know the teach-back method? Are we asking the 5 whys? Are we sitting across from our patients as we talk to them? I mean, there's some key elements that we can do to improve the quality and delivery of care. And if people don't believe me or are saying, oh, this is a very strange talk and very different than the other talks today, I'll ask you this question. How many of you had a teacher in school that you absolutely hated? Yeah, everybody, it was my Irish teacher, Mr. Brady. Yeah. And how many of you did your best for that teacher? We've said, I'm going to get out of here as easily and as quickly as possible. I'm going to keep my head down. So when the doctor says, do you have any questions? No, I'm fine. So if we're not engaging our patients, we're not making them feel safe, we're not making them feel included, what's the likelihood of going to participate in the care process? And here's an example of just one I pulled last night after the conversation we were having at dinner. Is in a health affairs study in 2013 that studies shared decision-making, which is just one part or one tenet of patient-centered care. There's a reduced overall cost of 5.3% when you co-develop a plan with your patients. There's reduced admissions by 12.5%, and there's reduced preference-sensitive surgeries by 9.9% and 21% in heart surgeries. So when we talk about this influx and this weight we have, what about if we just actively talk to our patients about what they can realistically expect. Because if people knew the side effects, if people knew that the chemo that we were going to put them through might only work 50% of the time and might only extend their life by 3 to 6 months, people might make a very different decision. They also might make decisions depending on where they are, depending on where their goals are. But the key is we can't be paternalistic and maternalistic anymore and make decisions for them. We have to co-develop it with them. And when I say that, I'm not trying to remove the expertise of the people in the room, but instead elevate the expertise of our patients, because they're the ones who know best about themselves. And the evidence around this is robust. You're not supposed to be able to read this. You're just supposed to be very impressed at how long the list is. This is a study that we just finished with National Academy of Medicine in the United States, formerly known as the Institute of Medicine. We're building a framework for patient-centered care. There's over 150 studies that show the benefits and outcomes of patient-centered care, from a clinical outcome, from a satisfaction outcome, from an improvement for clinicians, and the quality of care and the reduction of their dissatisfaction with work. This is a win-win-win scenario. But yet people sit there and say, what's the proof case for this? Where's the evidence? The evidence is here, and I'd be glad to share it with anybody in more detail. Over 150 studies that promote and support patient-centered care. And here's the fancy magazines they've been in. But here's a reality check for everybody in the audience. Here's some studies over the last 10 years that show that, on average, physicians interrupt patients after 23 seconds. 50% of the time, physicians don't ask patients if they have questions. And if they do ask them if they have questions, what they usually say is, do you have any questions? And the normal answer is, no. Instead, if we ask, what questions do you have for me today, it creates an expectation of participation and creates a different kind of discourse. We spend less than 1 minute talking about medications, and because of fear, patients don't speak up. That's changing with our new generations, but because of fear, people aren't speaking up. This is why we need to think of our care in a patient-centered mindset. And for me, there's a framework that I think through, because patient-centered care, healthcare, it's been said many times today, this is a complex ecosystem that we're managing. And I'm not that bright, so I try and simplify everything down to measurable chunks. And the first thing we have to do if we want to be patient-centered, and this has been covered well today, is provide good quality care. All bets are off on everything else if we're not providing good quality care to our patients. But after we provide good quality care, the next thing is, how do we provide access to our patients? And by access, I mean access to their loved ones. How many of you have open visitation and allow a patient's family member to come in at 12 o'clock at night or 1 o'clock in the morning? No research says that infection rates go up. No research says there's any problems with it. What it does is increase the connectivity of families to one another. How are we giving patients access to resources and to information so they can make better choices? And after we give them access, how are we including them in the care process? Do we have care partner programs so that their loved ones are learning about their treatment when they go home? Because how many of your readmissions are because of patients who did silly things when they went home and didn't know about it? So how are we really including patients in the decision-making process? And then, and only then, can we have activated patients who take responsibility over their care, who can in turn make proper, informed choices? That's the hierarchy of patient-centered care, and that's how we need to think through it. In its manifestation, here's some of the sample ideas or services that you can provide. And the key is that you become an organization that's listening to your patients and respecting and honoring the fact that they're experts about them. Because many of your patients are self-medicating. Many of your patients have complementary things that they're doing. And if you can open up with them and have honest conversations with them, you can manage their health care better. Here's some examples that work, though. Care partner programs, patient pathways, patient-directed visitation, bedside shift report, patient-family partnership councils, shared medical records, so open medical records that patients can look at whenever they want. And I'll be around afterwards. I'll be glad to talk about any one of these. I can't cover them all in 20 minutes. But here's some real things that we can do to improve the connection and engagement of our patients. And over the last 8 years, we've worked with over 100 organizations around the world to develop a designation program. So we've now got 64 operational criteria that tell you how you can be patient-centered. So it's no longer this fluffy, esoteric thing that we'll debate. There's 64 operational criteria that you can work towards to achieve patient-centered care. And they fall in 3 categories: around your purpose, around your process, and around your practice. So instead of saying, okay, we want to be patient-centered, what does that mean? There's a literal definition of it, and there's a certification for it, and there's an approval process for it, if you want to go down that avenue. But for me, more important than any of that stuff, that's all business. That's the process that we've gone through with 700 organizations. That's the research out there. But the reason I do what I do is because of this little girl up here. This is Katie, Catherine named after her grandmother. So my daughter was born on May 19th, 2008. And on May 21st, 2008, I was getting ready to take her home from the hospital for the first time to see Manchester United play Chelsea in the Champions League final. And that's when Man United were good. Although we're back. We beat Man City last night, so we're feeling back very, very quickly. I was introducing her to the wonders of Ronaldo and Rooney, and instead I got a call from my wife that said, there's something wrong with Katie's heart. And at 4 days old, my daughter had her first open heart surgery. Over the next 5.5 months, Katie had 5 open heart surgeries and 4 heart catheterizations before she died. During that time, she suffered neurological damage. She was the first patient with her diagnosis that clotted. So every time they did surgery, she clotted from the chest up. Where at one point, I turned to the doctors and nurses and said, about 5 o'clock in the morning one day, does Katie's head look big to you? And they measured her head circumference, and her head had doubled in size because the blood was just staying up in her head. It was a really, really difficult time. And it was during that time that I saw the good, the bad, and the ugly of healthcare, where I knew that every night at 6:30 before shift change, I'd ask the nurse, who's on tonight? And depending on the answer they gave me, I knew if I could sleep that night or if I had to stay up all night. It's that inconsistency, it's that juxtaposition that we're worried about. No cyber knife fixes that. No advanced cancer treatment fixes that. That's about making sure people are putting their best foot forward. This is Katie, my wife Vicky, and I this week, 8 years ago, a week before Katie died. This is why we all do what we do. And I'm not telling you this story to make you, it was easier to talk about some of the challenges and blame the government. It's a much easier conversation than there's people like this in your organizations right now. And I'm not trying to hijack the day because of my 5-month-old daughter. Every one of you has a Katie. Every one of you. She might be 5 months old, she might be 85 years old. Every person who comes through our doors deserves the best quality care. And we were talking last night at dinner about the golden rule. And everybody learns this in medical school and nursing school. Treat others as you want your mother treated, or treat others as you want to be treated. And I would say that's not good enough anymore. We need to elevate to the platinum rule, which is treat others as they want to be treated. Because it's not good enough for me to say, well, I want this, so you'll want that too. But instead, we need to understand, what do you want? As sobering as a story is, and as tough as a story is to hear, I'm actually a positive guy. I'm more than glass half full. I think there's amazing things happening. The fact that this conference is happening today, the fact that the conversations that we're having around including patients, partnerships, and planning is happening the way it's happening, means we've made great strides over 20 years ago, 30 years ago, 40 years ago. For those of you who were around and providing healthcare back then, you know how different it was. And we can glorify those days, but we know they weren't perfect. So I want to leave you today with a story of hope. There's great things happening. The 2020 plan that's happening here gives me great hope for healthcare, for my family, for your family. But the hope I want to leave you is when my daughter was born, I hoped that she'd change the world. I'm not talking about a doctor or a nurse. I'm talking about Martin Luther King, Nelson Mandela, or Mary Robinson. The bar was high for Katie. Then she got sick, and I hoped that they'd make her better. And then she got really, really sick, and I hoped that she could be out of the pain that she was in. And then she died. And then, and now, I still hope that Katie's in a better place. So I never lost hope. Hope adjusts with the reality that we have in front of us. But as I said, right now as we're speaking, there's scared people pulling into your A&E or sitting in your ICU who deserve the best quality care. So all we can do is provide them with the best hope we can. We can't fix all the problems in the world, but we can make sure that every time we interact with one of our patients, we engage with them the best possible way. And I'm not talking about from a patient satisfaction standpoint. I'm not talking about rainbows, butterflies, and unicorns and all the sweet stuff that goes along with care. I'm talking about being decent human beings and connecting with them. And that's one thing that the Irish are great at. We should have the corner on the market of having the most patient-centered and connected staff in the world. And we do. But we also don't, depending on the shift and depending on the person. So I'm here today to encourage us to get more consistent and to drive that hope so when it's us, because we're all one step removed from receiving that care, that we can receive it in the best way possible. With that, I'll leave you, and there's a couple of resources up there if it could be of help to you. Thank you all very much for your time.